My name is Paul Huntley. I am Scottish. I live in Singapore. Work all over the world with different people who handle infectious disease agents. A lot of my work is in hospitals. Some of my work is with big laboratories, people like World Health Organization. So last week I was training people on poliovirus and poliovirus controls. So my life really is working with organizations who either deliberately or just through the course of their work have to handle dangerous microbes. I've been working in this area for about 15 years, and some of the areas that I work in you might think are very high risk. So laboratories that handle smallpox, laboratories that handle Ebola, very high risk. Actually, they are not very high risk. They are major hazard, but the risk is very small. The chances of harm to the workers is low. The chance of harm to the community is very, very low. And I started working in hospitals maybe 7 years ago. One of the things I realized was the risk in hospitals is much, much higher than it is in these facilities. And the real risk in hospitals often is not MERS, it's not Ebola, it's everyday organisms that exist in the hospitals that have a huge impact on the patients. So what we did was we sat down and we said, okay, let's develop a standard for hospitals that looks specifically at infection prevention and control. And it might look at some of the exotic organisms, so SARS, etc., but really also focus on some of the simple things that cause real harm to ordinary patients every day of the week in hospitals all around the world. And that's what we've been trying to do with the Managing Infection Risk Standard. So it's a standard that sets out a management system. And management system can be a little bit dry, can be a little bit boring, but actually this one is, I think, quite interesting. And I'm going to talk about it today, not in a very formal management system way, but to try to explain what the standard tries to do, give you some examples of the areas that we discuss with the hospitals, and then most importantly, my friends and colleagues are going to give you their experience from a user perspective in Thailand. So both HA, who've been participating in some of the assessments, and Bumrungrad, who've been through this assessment, and we hope very, very soon will become the first hospital in Thailand to become a center of excellence for managing infection risk. So the objectives introduce the organization, DNVGL, a big international organization based in Norway who do a lot of work in healthcare. Talk to you about managing infection risk, give you some practical examples, and also this is not such a serious presentation. So we're going to talk a little bit about the theme of the conference, because I think one of the very interesting things about the standard is it has been a very good tool for the hospitals in terms of communication, in terms of understanding management systems, etc., using infections as a theme. So we have a few photographs, etc., and a few different areas that we can discuss. Hopefully we will not take all of the time. So if anyone has any questions, we will be able to take the questions at the end. DNVGL, based in Norway, an organization which really is about managing risk in major hazard industries. So originally in maritime, but also in areas like oil and gas, nuclear. And one of the interesting things is that my belief is that these other industries are very small in terms of risk compared to healthcare. So as an individual, when you go to hospital, you are exposed to a significant level of risk which goes way beyond most of these other industrial environments. So what we try to do with MIR and other services is bring some of the knowledge from these other industries and apply it to healthcare, which is a very, very different environment. So if anyone tells you a hospital is just like an aeroplane, I think they are confused, because a hospital is much, much more difficult to control than an aeroplane, because you've got lots of people there with different conditions, different susceptibilities. You've got a very, very complex organization, but I believe you can still take some of these principles and apply them to healthcare without saying a hospital is an oil rig, or a hospital is a nuclear facility. It's a very, very different environment. DNV, 151 years old, so quite an old organization. In terms of healthcare, actually one of the bigger organizations throughout the world. So a very large certification organization working with about 2,500 different healthcare organizations around the planet. One of the big accreditation bodies in the US, doing international accreditation also in a number of different countries. So there is a general accreditation service. There are a number of different ISO type standards which are of interest to the hospitals, so things like 9,000, 14,000, etc. But the specialized area that I work in is the control of infections. So the two major standards that we use most of the time, one is the International Accreditation Standard, which is very similar in nature to the JCI standards. But the one that I have been working with almost exclusively for the last few years is the Managing Infection Risk Standard, which complements accreditation. And some people ask us, why is there a special standard for managing infection risk? And the answer is really that this is a very specialized area. And during a major accreditation survey, there just is not the time and opportunity, and often not the expertise, to look at this area in really great detail. So we would say that during an accreditation survey, we would look at infection control under the magnifying glass, but during an MIR survey, we look at it under the microscope. So we really go in detail into the program, how it works, the results, etc., right down to implementation in the different areas which are important. And managing infection risk is based around 18 different elements. So the structure has been developed over a number of different years. Some of the elements are very technical. Some of the elements are very organizational. So the first element, which is really looking at organization, looks very similar in nature to a quality management system. But it's asking questions about policy. It's asking where people set objectives and targets. It's asking about internal audits, etc. And basically saying, are you an organization? Do you set consistent expectations? Do you look to see that these are met, etc.? Or are you a group of different departments, different individuals who may not be working together to meet the organization's objectives? So it's quite a big element, but focuses specifically on infection control. There's then another element which I think people have found very interesting, which is risk assessment. And risk assessment really looks at the way that people identify hazards and risks in the hospital, I think in a way which is slightly different to what has often been done before. So there's an expectation that there will be risk assessments, that they will be formalized, that they will be documented, and there are many, many different areas where you could do risk assessments. So one of the things the standard is doing is really, I think, starting a discussion in terms of what type of risk assessment should be done in healthcare, what techniques should be used, etc. Then we begin to get into the more technical elements. Some are about antimicrobials, some are about healthcare and vaccination, some are about the buildings, and I'm going to go through some of these in a little bit of detail as part of the presentation. But basically it's around 18 elements. It covers everybody and everything in the hospital. So if you're a receptionist, you're part of MIR. If you are a security guard, you are part of MIR. If you are a housekeeper, you are a critical part of MIR. Okay, so it's not just about doctors and nurses, it's not just about antibiotics and pharmacists, it's about everybody in the organization and the role that they play, and they must be formally part of this system. And the theme for the conference, we do, I think is very, very relevant to this particular standard because it really does involve and engage everyone. So the first element is the infection risk management system. Basically, the question you're asking is, Are you an organization? Do you have consistent policies? Do you have control, etc.? So one of the first things it does is it says that in the hospital there is a leader, usually the chief executive. What is the chief executive's role in managing infection risk? So the standard takes this away from a technical discipline to an organizational responsibility. So in the first element, it asks lots of interesting questions about what is our policy? How do we try to have consistency? How do we try to implement good practice? How do we, in a structured way, set objectives and targets? And most importantly for the boss, how do we know that we have adequate resources for managing infection risk? So it's a very big element, but at the center of the element is this idea that this is an organization with leaders who will set consistent expectations, etc. And that can bring a certain degree of tension because some of the elements are quite clinical. So a very good example is antimicrobial stewardship. And basically you're asking the question, who decides what the policy should be on dispensing antimicrobials? And historically there has been usually a large degree of discretion in terms of what antimicrobials might be dispensed. And the standard is saying that our leadership says we should have policies and we should follow these policies. So some of the discussions for some of the hospitals are quite interesting in terms of, is this an organization where we set the rules and we monitor, etc., or is it an organization where people have tremendous discretion? And of course the truth is it has to be a balance between the two, but the formalization that comes through this particular element in terms of setting consistent expectations is really quite interesting. Another part of this element, which is very, very tricky, is the area in terms of contractors and suppliers. Because hospitals used to be an organization who employed everyone, and more hospitals are becoming organizations comprised of a number of different contractors. And it probably started with kitchens, then it went to security, but now you find in many of the hospitals, some of the contractors are key clinical elements. So dialysis, areas like CSSD, and I think this is something that may continue in the future. And managing contractors in many industries is known to be a very, very difficult thing. So the standard puts clear requirements to say, if you have a person who performs a job, we don't care if it's a physician, we don't care if it's a nurse, we don't care if it's a housekeeper, we don't care if they're employed. If it's a contractor, they must be competent in that particular position. And the way that you gauge competence and control competence for contractors is often different to the way that you do it for staff. And of course, one of the really tricky areas is how do you gauge competence in physicians? Because they have different mechanisms. They have credentialing, etc., which may be entirely appropriate, but the standard says if a physician is going to insert a catheter, are they competent? Have they been through the training in the bundles? Can they demonstrate they understand the equipment, the environment, etc.? So there's many interesting areas in the first element which asks about what type of organization is this and what is the focus in terms of managing infection risk. The second element is risk assessment, and there is an expectation that not only will risk assessments be done, but that the hospital will decide as an organization this is what risk means to us. This is when we will do a risk assessment, this is who will be involved, this is the technique that we will use, this is how it will be done, this is how it will be reviewed, this is how it will be updated. And there are many, many different areas where you might do risk assessments. You might do risk assessments on a building, you might do them on a bundle, you might do them on an emergency, you might do them to select PPE. And this has been an area which I think has been of great interest to the hospitals. How can we move away from what in many cases has been a fairly simple understanding of risk assessment to something which is maybe a little bit wider, that covers more areas, uses different techniques. And many of the hospitals who've been doing these risk assessments are reporting that they are seeing some significant benefits. So the risk assessment element is really there for infection risk, but it also applies to medication management. It can apply to falls, many, many different areas of patient safety. So it's one of the ways that the standard actually, although it focuses on infection control, people very quickly realize that some of these techniques, etc., can be applied to lots of different areas. This is an example of when risk assessment and risk management goes sadly wrong. So this was the MERS situation in South Korea. A very good example, if you read the reports, of how the risk management can fail catastrophically. So very, very big outbreak, very high profile, etc. Very damaging to the hospital, but most importantly, extremely damaging to the patients who were involved. And to be honest, these situations, they could often happen to any hospital. And a lot of risk assessment is looking at these simple things that can go wrong that can prevent this going from a serious incident into a major crisis. So we get many of these instances at the moment. And the idea of risk assessment is that you use a preventive way of thinking to make sure that when you get one of these patients, they don't result in a major outbreak. Antimicrobial surveillance, antimicrobial use is a major part of the standard, looking at the way that people look for infections but also select antibiotics, etc., in order to try to minimize the risk of resistance and make sure people get the treatments that they require. And Sir Alexander Fleming, I always like to use this slide because obviously he was Scottish. Many good things invented in Scotland, including antibiotics. So many, many years ago, during his Nobel Prize-winning speech, he said that people would need to be very, very careful, because if they're not very, very careful, they are going to have antimicrobial resistance. That was 1941. So I can't even think how many years ago that was. That must be, what, 80 years ago? Close to 80 years ago. We still have the same issues today. And what the experts say is we're running out of antibiotics. And it's not just the infections that we need to treat, it is the impact that this is going to have on general surgery, etc. Impact it's going to have on cancer care. So one of the things the standard looks at is to say, we all know this is important, but the standard is going to require that you really sit down and say, what does this mean to your organization? How are you going to control it? What is good practice? What are the current standards, etc., that people are following so that they have a formal system in place to control the use of antimicrobials. Emergency response and contingency planning is quite an interesting element also, because there are basically two types of emergency. Some are what I would call general emergencies, so something like a fire. Other ones are very much infection-related emergencies. So if you have a fire and you have isolation patients, if you have highly susceptible patients and you need to evacuate them, what will happen? If you have an outbreak in the hospital, what will happen? And very often there are some plans which are very, very high level. So a good example is that you have a MERS patient and you have an isolation room and you have a team. What happens if you get 2 MERS patients? What happens if you get 10 MERS patients? What happens if you get 50 MERS patients? So the element really looks at some of these areas and says, are we really prepared for what could happen? Or are we making some assumptions which may or may not be correct? And it's led to some very interesting discussions in the hospitals in terms of not just what are the types of emergency, but what could be the scale of those particular emergencies and how would those be managed. Personnel and competence is looking at the way that people are recruited, the way that people are trained, but most importantly that the people are competent. So competence is defined as your ability to perform the work in the workplace under the conditions that you will experience in reality. It's not sitting in a classroom listening to someone like me. It's not clicking on a computer to go through your average training. It is standing there beside someone who is uncomfortable and complaining and trying to do some very, very practical things. Areas of competence that are raised, which I think are interesting. Often nursing work in the role of a housekeeper. They need to use disinfectants, they need to do cleaning in some very, very critical areas. Have they ever been trained in these areas? We mentioned physicians. How do you detail physician competence? If it's a visiting physician who maybe only spends a few days in the hospital every year, do you have the same expectations as an employed physician? So basically it's about saying, what job do people do? Are the people trained, and can they demonstrate competence irrespective of their job title, irrespective of their normal role? And again, it extends into all the different departments and all the different people. Human factors, which are the behaviors, the attitudes. The classic human factor is hand hygiene. So hand hygiene is all about human factors. It's all about behaviors. It's about believing. Yeah, so one of the big problems with infections is that in many other industries where you have an accident, you have a bang, you have a crash, you have a fire. If you infect a patient with your hands, what happens? Nothing. 3 days later, you're sitting at home watching the television, and someone says, "Oh, I feel very warm." You have no connection to the accident, which makes it very, very difficult for people to understand how critical simple things like hand hygiene are. And this is all part of human factors. And when we talk to the hospitals, when we do the training, we say, how important is human factors? Everyone says 10 out of 10. And we say, how much time and effort and money do you spend on studying and improving human factors? Not very much. So again, there's an expectation that we don't only look at the operating room and the equipment and CSSD. We look at the way that we think. We look at the way that we act. We talk about, why do leaders not lead? Why is it that I can walk into a room and I can see several different things happening that everyone knows should not, but the leaders in that room see the same things and they don't act? And that's often because these are very difficult conversations. Yeah, but this is part of the problem. This is what we would call the elephant in the bathroom. That we need to look after each other. We need to tap each other on the shoulder and say, excuse me, you just did this, or you just did not do this, and the other person should say, thank you. So human factors is one of the very, very important elements, but very soft. But again, there's an expectation that you will look at this in a structured way. You will have processes. You will look at what is good practice. You will monitor, you will measure, and you will improve. Facility requirements. I have seen, 50 hospitals. I have never seen two the same. I have seen in one hospital 5 different types of isolation room. I have seen right-handed rooms. I have seen left-handed rooms. I have seldom seen a room that is too big, but I have seen many, many rooms that are too small. So the way that hospitals are designed, the opportunity for standardization, etc., I think is huge. Some of the hospitals are big hospital groups, and there's a really big opportunity to look at the designs, own the designs. If there are problems with architects and suppliers, it's really important the hospital really understands these designs themselves and has a very structured risk assessment, specification, and design process. So the buildings, big issue, lots of money. Everywhere you go, you see problems. Many of the problems can be solved relatively simply by implementing more standardized design procedures. So that is part of facility requirements. Healthcare environment, very, very important. Laundry and linen, kitchen. The support services who not only need to provide services which are of a very high quality, these are people who go into the patient rooms. These are the people who come into close contact with the patients on a daily basis. If you don't have clean rooms, you have got a big problem. So these are not support people who live down the corridor and do a little bit. These are absolutely central people in terms of controlling infections in the hospital. So we spend a lot of time talking to laundry, linen, kitchen, housekeeping, etc., not just to tell them that they're important, but to talk to them about how they can systematically improve the work that they do in relation to infection control. And once you tell them that they're important, they absolutely know. They understand all of a sudden, I'm not just cleaning a room, I am potentially preventing infections. And we've seen some great results where people have looked at these activities and really shown measurable improvements. Cleaning, disinfection, decontamination, two sides really. One is when you have potentially hazardous materials. So maybe a material which is contaminated, etc., which could be anything from surgical dressings, it could be curtains. Hospitals are no longer hospitals. Many hospitals have become hotels, so they have lovely cushions, they have nice frills. For me, very difficult to clean, very difficult to decontaminate, etc. So looking at some of these very, very simple areas, and then of course the other side is things like sterile supplies. So how do we maintain very, very high levels of cleanliness, sterility, etc., through cleaning, decontamination? So again, lots of time in places like CSSD, lots and lots of time in endoscopy. So looking for processes which are vulnerable, because generally if you want to do a good decontamination or sterilization, you add lots and lots of heat. If you add heat to endoscopes, they don't work very well afterwards. So you have a process which by definition is challenging. The environments are often challenging, etc. So we spend lots of time in places like endoscopy. Sadly, in recent years, there have been some examples of where this has gone seriously wrong. So there have been instances where there have been a number of infections through the things like the misuse or poor processing of endoscopes. And again, when you go to the hospitals looking at the simple step-by-step processes in areas like endoscopy, you've got the potential to prevent a major incident. Patient care, which is really at the center of the whole exercise, which looks at the clinical pathways, looks at things like bundles, really looks hard at competency, etc. I think at the moment the standard is really in its infancy, so it's still quite new, but I think in 10 years' time we might be having a very different discussion about clinical risk assessments based on infection control. People tell me in some of the hospitals they have 15 surgeons and they have 15 different ways to change a knee. That may be ideal, but for me that sounds like there might be quite a lot of variation in some of the processes. And again, the focus is really to look at what is done. Is it evidence-based? Is it good practice, etc.? So a lot of time in cath lab, going to some of the really critical areas where high standards have to be maintained, going to the ORs, etc., ICUs to look at the practices there. Singapore, where I currently live, please don't tell the Singaporeans that I showed you this slide. They had a very bad experience, I think 2 years ago now, with hepatitis C. The truth of the matter is they really don't know what happened. So there was an investigation. If you want to learn a lot about some of these areas, read the investigation reports and then draw your own conclusions in terms of, was this really the cause, or do we really not know what the cause actually was? But there was a big outbreak, resulted in a number of fatalities, hepatitis C, and of course the finger was pointed very firmly towards breaches of infection control practice. To be honest, some of the breaches they pointed out, I think you could go to many, many, many hospitals and see very similar situations. So I suspect in this case there was something which went catastrophically wrong, but again a very good example that when it happens, very serious for the patients, very serious for the hospital, etc. Hand hygiene, huge problem. Hospitals struggle everywhere with hand hygiene. Lots of different ways being invented to try to improve this. And again, the standard says that you will have a program. The program will be systematic. You will measure, you will monitor, but also the elements all interconnect. So if you have a supervisor and they have a 30% hand hygiene rate on that particular ward, the question should be asked, what is the responsibility and the accountability of the leaders in these units? Should these people get a bonus? Should these people be rewarded? So lots of good discussions around hand hygiene, personal responsibility, leadership, etc. And everyone says it's such a big issue, it's the biggest, etc. in hell. And you go in and you say, what's your policy on jewelry? Why do all these people who need to sanitize their hands have enormous watches, big diamond rings, sleeves which come down to here? This is really one of your number one priorities? So really asking some of the difficult questions, not just in terms of the theory, but when you walk into an OR, you should not see finger rings. You should not see watches on wrists. Should you see mobile phones? You should not be seeing mobile phones, but I can tell you, if you want to call somebody in the OR, there's every chance they might pick up, at least in some of the hospitals, some of the time. So again, looking at some of these areas and saying, what are we doing? Can we do it better? Clothing and PPE. So again, one of the problems in healthcare is that you have to get very close and personal with the hazard, which is often a human being. So the areas where I work, what we try to do is we try to keep it inside a cabinet. We try to keep it inside a bottle. We try to keep it inside a pipe so that we have primary containment. So PPE becomes much less important because you're not exposing the worker. In healthcare, that's much more difficult because you have to handle the patient. So there's the risk of the worker infecting the patient, but also in many cases, the patient infecting the worker. And one area of which I think has really raised concern has been Ebola, has been SARS, has been MERS, where there's been a huge reaction in terms of the workers concerned that they themselves may be exposed, may be infected, may take this home. So PPE is a very important area, but it's often handled very badly. There are rules that people do not follow. The logic of the PPE controls is not always clear. And the most notable example that we've had recently was with Ebola, when, surprise, surprise, we found that maybe we're not quite so good at putting PPE on and taking it off as we thought we were. And Ebola is very interesting, but for me, the really, really interesting thing is, if it happens with Ebola, do you think it happens with MRSA? Do you think it happens with C. diff? Absolutely it does, just the same. It's just that you don't see the same outcome when you get transmission through some of these other pathways for some of these different organisms. So Ebola, very interesting because it raises attention of these particular issues, but actually we can take the same thinking and apply it to some of the day-to-day organisms which actually cause the real harm in the hospitals. So the hospitals who are doing MIR, the ultimate objective is to become certified as a center of excellence. And it takes a little bit of time. It takes quite a lot of thought. Poor Jania's going to talk about some of her wonderful experiences of sitting in a room with me for many hours talking about infection control. But it really is something that you need to take a step back. You need to think about where you're going, what you're doing, how you're organized, etc., using infection control as a theme. I think the hospitals get a lot more than infection control from this particular standard because I think it really helps them understand management systems using some very, very practical and obvious examples associated with infections. And the way that the process works is at the beginning we go in and we basically do a gap assessment. And we say, this is where you are. Where would you like to go? How quickly would you like to go there? And we do some training, and then in the gap assessment, we basically train the whole organization in terms of this is your role, this is why you're important, and this is what we're trying to do. And we have had very, very good feedback and response from these exercises. The people seem to be genuinely interested in talking about this in a way that maybe it has not been presented to them before. Then there can be trainings, other gap assessments, etc., before the certification visit. For most hospitals, probably take 1 to 2 years to achieve certification. Some may be quicker, some may take more time, but it's not something that happens at the end of the first week. It really is very much a journey. And these are some of the hospitals that we've been working with. I'm very happy to say that finally in Asia we have got some momentum. Much of the early work was done in the US, but my own personal mission is to bring this to Asia, not just to Thailand, to countries like India, to countries like Vietnam, countries like Bangladesh, where the problems with infection control are massive. 40 to 50% hospital-acquired infection rates in some hospitals in India. If you could drop that by 5%, what a difference you could make. And you'd be making a difference to people who really cannot afford to be in a situation where they are sick, where they are hospitalized, and they are getting sicker and sicker. So I am very grateful to Thailand. I'm very grateful to the hospitals who have been working with us in this, and I hope that in years to come we won't only be doing it in some hospitals, but we will be doing it in many. And I think the relationship with HA is very, very important in Thailand in developing the program here, and hopefully it will extend to many other countries also. So I just have a few photographs to conclude. A little bit lighter, a little bit away from some of the theory. MIR is not all about documents. Okay, I find documents extremely boring. But people bring documents and they often have to bring them on wheels because there are so many and they are so heavy. And we need to make sure that there is a system. So quite a lot of the time at the beginning is to say, how are you organized, what are your standards, etc. But really the interesting part is when you go into the hospital and you connect the theory with the actual practice. So part of MIR is about documents, but really that's not the main focus. The main focus is, have we identified good practice, and then do we use the documents, the training, etc., to make sure the people who do the work know what to do, and they do it every time the right way. It's about working together. So often we go into a room, and I would be used to going into a room where there would be 6 people, and there would be 60 people. And the people would be interested, what have we done, what have we found, questions from all kinds of people. So it's really about working together, and it really shows that any one group in the hospital cannot control infections. For sure, the infection control officer cannot control infections. That is an advisory person. Everyone has to do their part. And again, we have many, many examples of good teamwork, people working together, engineers coming up with examples of how the hospital can improve infection control, etc. I don't know if you recognize this gentleman. Very, very important to have good leaders. So Dr. Montre has been a very good leader, not only for HA, but in his own hospital. Janya has been another example of someone who has really taken this and said, I think this is something worth trying. I think this is new. I know this is not going to be so easy, but I think it's something that we should do. So really having people in the organization who are going to champion this, who are going to say this is very important and going to do it. And it's not a legal requirement. There is no regulator saying you must do this. So the hospitals who are doing it, they are doing it because they believe it's the right thing to do, which I think is the right reason. In individual hospitals, demonstration of leadership. Hand hygiene is important to me. It should be important to you. One hospital we visited in the US, and I was talking about leadership, and the chief executive said, should I come in on Monday with a t-shirt saying, I love infection control? And he was joking. I said, you absolutely should. What a difference that would make to your organization. In Thailand, we see this all the time. We see posters, we see presentations, we see senior leaders in the hospital standing up and saying, this is important to us and this is important to our patients, which is very, very important. People are interested. I wouldn't say they're always interested when we go through the documents, but generally the people understand what we're talking about. They don't get tied up in management system theory and auditing because we're talking about, is it clean or is it not? Are you contaminated or are you not? Do you know what your supplier is doing or do you not? Do you know what antibiotics your physicians are prescribing and are they the right ones or do you not? So it's a very, very practical and applied subject. And generally, we don't get feedback that people don't understand. We don't get feedback that people think it's boring. They see it for what it is, which is a really, really important area. This is the one in the middle here. This is me. You might not recognize me, but actually that's me. So we go into some of the clinical areas. We go right back to basic principles and we say, how should an OR work? Do you know what happens to the air in your ORs? Do you know what happens with the air in your isolation rooms? So we go in and we start to ask the questions, we take some smoke, and people begin to see that they work in an environment which is designed in a particular way. Often they have no idea how it has been designed. Okay, so a lot of it is very practical, going into the critical areas to have discussions in terms of how the work should tie in with the facility, and if it doesn't, that can be a big problem. CSSD, very, very important area. So we go in there. CSSD are very lucky because they have lots of standards. They have big, thick books. When they give me the book, they always say, please don't take the book because it costs $450. I go to tube feeding in the kitchen, there is nothing. So again, some areas are very fortunate because there's lots of standards and guidelines. Other areas, it's really more difficult and much more about risk assessment. But these are some of the critical areas. Another very, very critical area, this is the kitchen. This is the lady who handles the dishes. And if she doesn't handle the dishes properly, and she has an isolation patient, what happens to the plate? Next time, it may be off to cancer care. So if this lady here doesn't know that this is the clean side, and this is the contaminated side, and there's only one person, and the poor soul is very busy, so she puts them in here, and then she comes here. No change of PPE. Do I have clean dishes? 5 minutes is all it takes to explain some of these things to some of these people, and all of a sudden they begin to realize the importance of the procedures and the PPE changes, etc. This is a transport team from one of the Phaya Thai hospitals. You will never see more interested and engaged people in your life. They want to know all about transport. They want to know how they should be cleaning the equipment, where they should be storing the equipment. Should they wear gloves? Should they not wear gloves? Absolutely engaged in the process and understand the role. Smoke testing in an OR. So again, very, very simple, but if you don't understand the environment, you will never get the benefit of the engineering controls. So some of the most interesting things we do are going into these environments and talking to people about how they work. We don't always know, to be perfectly honest. But we can usually have a discussion. This is the theory, this is what we're seeing, etc., and it changes people's perspective. This is a portable HEPA filter. So you will see that we use some very, very expensive and sophisticated equipment when we do these assessments. But this was a very good example because this filter blows 360 degrees. And I am the worker, and this is the patient, and this is the filter, and my 1,000 baht note shows that when that patient coughs, it's coming straight to me. Okay, so again, applying very, very simple theories, directional airflow, what is the equipment designed to do? Because if you don't, this piece of safety equipment becomes a real hazard. Okay, so it's not all antimicrobial programs and management. A lot of it is really, really simple common sense and taking it to the people who need to know. And this was some work that we did training the HA auditors. And I am a firm believer that people like me can only be partially effective in different countries, and this really needs to be embedded in the country. And you can see this week, I think there's 7,000 people at this conference. So if we can work with HA, different organizations, to bring this not to the few hospitals, but to the many, I hope we will see some real advances in infection prevention and control. So that's pretty much all from me. Just have a few conclusions before I pass over to the others, and then we can take some questions at the end. Are we winning or losing the battle against infections? There's a new significant infectious disease emerges roughly every 2 years. What have we had in the last decade? We've had Ebola, we've had SARS, we've had MERS, multi-drug resistant tuberculosis. So this is something which is going on and on and on. More and more people want to eat meat. When they want to eat meat, it's often pork, it's often chicken. You are beginning to build industrial-sized generators that can potentially provide the next big infectious disease issue. So on one side we have that. On the other side, are we really dealing with C. diff? Are we really dealing with flu? Are we really dealing with measles? So the microbes are getting very smart. Antimicrobial resistance, I think we need to do some new things in order to keep one step ahead. The opportunity for both public and private hospitals, I believe, is very large, not just because of infections, but because this really crosses over into good safety management practice, good quality management practice. It's not all about infections. It's really about organizations. It's about risk assessment. It's about structured policy setting, ownership down to individual level. So I think it's a very interesting standard, even for hospitals where infections are not the number one priority. And I would be surprised if there are many of those. Everyone has to be involved. So if you're the housekeeper, the transporter, the senior physician, everyone is involved with MIR. Really cuts across every department and every activity. I think that we have a real potential with this to release the inner power. I think it really empowers people. It gets people to understand their responsibilities, understand their ownership. And that's, for me, probably the most exciting thing about doing this work, is it's not DNV standard. It's not necessarily even Bumrungrad standard. When you see the guys in Bumrungrad in the mortuary, you go back the second time and they say, we've changed our PPE. We now have all our instruments cleaned in a different way. You begin to see that you're reaching the people who actually do the work. And that really is giving the people the opportunity not only to work more safely, but also to help the patients. So thank you for your attention. I will pass over to Dr. Montre, and then at the end we can take some questions. Thank you.